Hello, everyone. Thanks for the invitation to speak about this topic. I'm going to be focusing on the concept of ESUS and what the latest data show us about how to manage ESUS. And just to give a quick definition of ESUS, it really springs from this original concept of cryptogenic stroke. And even in 2019, with all the advanced imaging we have and advanced diagnostic tests that we have, about a quarter of our stroke patients still don't have a defined etiology or defined mechanism. They have risk factors, obviously, that we know about, but we can't pinpoint exactly what the sort of proximate mechanism of the stroke was. And clinically and radiographically, many of these cryptogenic strokes look embolic. So when we're evaluating these patients, our hunch, our sort of clinical instinct is telling us that these were clots that arose from somewhere in the body, traveled to the brain, caused the blockage, and caused tissue infarction. But we can't pinpoint exactly where that clot originated from. And given that perception that a lot of these strokes are embolic, the term embolic stroke of undetermined source was introduced in 2014, and this ESUS concept sort of tightened up the definition of cryptogenic stroke. It gives a better sense of what we think the underlying mechanism or mechanisms are, and there's some sort of recommendations about a minimum workup that you need to do before you can call a stroke ESUS. So the question I want to focus on for this talk is, if we think that these ESUS cases are embolic, why would we not just anticoagulate these patients, right? We know that in general, embolic mechanisms, certainly cardioembolic mechanisms, respond better to anticoagulation than aspirin, so why not just anticoagulate folks empirically? So this is where we start looking at some of the recent trial evidence that I'm sure a lot of you are familiar with, but I wanted to review before moving on to what we think the next steps might be. So there have been two recent large multi-center randomized clinical trials of anticoagulant therapy versus standard antiplatelet therapy for patients with ESUS. And the first one to be published was the Navigate ESUS trial. And I put up the table 1 here. As you can see, it was a very large trial. Over 7,000 patients participated. On average, these patients were in their mid-60s, and they had a fair burden of vascular risk factors, sort of what you would expect from this population. And these patients were randomized to either standard aspirin therapy, which is, used to be, and I would argue remains the standard antithrombotic treatment for ESUS, versus rivaroxaban in the Navigate ESUS trial. And contrary to what I think a lot of us had hoped and perhaps expected, there was really no benefit in terms of reducing the risk of recurrent stroke with rivaroxaban compared to aspirin. You can see the Kaplan-Meier curves here are almost indistinguishable. And sort of more numeric detail, you can see that the primary efficacy outcome, which was any recurrent stroke or systemic embolism, was not reduced with rivaroxaban, nor were the other secondary outcomes of ischemic stroke or any recurrent stroke, while there was an increased risk of hemorrhagic stroke. The other trial that was announced shortly after Navigate came out was the RESPECT trial, the RESPECT ESUS trial. And this trial was very similar to Navigate, but involved patients, it used dabigatran instead of rivaroxaban. And it was also a large trial, over 5,000 patients, very similar baseline characteristics as in Navigate. And really, again, the difference was the choice of therapeutic agent. But the results were very similar. No significant difference in the risk of recurrent stroke with dabigatran compared to aspirin. So given these two trials that were neutral and frankly disappointing, I think the question in the field is, where do we go from here when it comes to antithrombotic management in ESUS? The original hypothesis underlying the ESUS concept was that these ESUS cases are due to some kind of occult embolism, either from the heart or from large artery sources, and that these various sources of emboli would respond to anticoagulation, so why not just anticoagulate everyone? And that empiric strategy, unfortunately, does not seem to be productive. So what do? I think one option, which would, you could reasonably argue for, is say, look, good enough. Aspirin is good enough, right? 5% risk of recurrent stroke per year is not terrible. Aspirin is easy, cheap, safe. We have a lot of experience with it. So just say that this is the standard treatment for ESUS, and let's move on to other sort of research topics. The other alternative argument is that this isn't good enough. 5% is not good. 5% risk of recurrent stroke per year is really high. Recurrent strokes tend to be very disabling and more severe than the index stroke. So we have to do better. And the ESUS motivation is correct, that there are better treatment options for these patients, but maybe ESUS is heterogeneous. We have to dig a little bit deeper, figure out the right subgroups, and find better treatments for these different underlying causes of ESUS. So I would argue for the second option, and we had a recent review paper where we made the case for why we can't just stop where we are now, and we need to better dig into the different underlying mechanisms of ESUS. This was our attempt to kind of put together a schematic of what we think might respond better to antiplatelets versus what might respond better to anticoagulant therapy, and then try to do further randomized trials of personalized treatment for these different subgroups of ESUS. And one topic that I want to highlight further in this talk is the group in the light blue at the far left corner, which is atrial cardiopathy without atrial fibrillation, just because it's something that I've been working on, and we have an active randomized clinical trial ongoing for this subgroup. So it seems sort of topical to talk about it. The concept of an atrial cardiopathy or atrial myopathy has been gaining a lot of attention and recognition over the past few years, both from the vascular neurology side and from the cardiology side. And you can see this in all these review papers that have been published over the past few years. And based on some of the sort of unexplained aspects of AFib, the relationship between atrial fibrillation and stroke, I think it's becoming increasingly clear that this simplistic story of fibrillation in the atrium causing stasis and causing blood clots to form is not the whole story. And we and other groups have shown in several different cohorts of patients that there's a relationship between markers of underlying atrial substrate abnormalities like left atrial size, markers of left atrial fibrosis, elevated natriuretic peptides, that all these different markers are associated with the risk of stroke, even independent of atrial fibrillation, or even in patients who don't have AFib. And so perhaps some of these puzzling aspects of AFib and stroke, for example, the fact that you can have a few minutes of AFib today and have a stroke several months from now, which doesn't really make sense if you think that AFib is the actual mechanism, that perhaps those puzzling aspects can be explained by the fact that it's the underlying atrial substrate that today is causing AFib, and then a few months later is causing embolism to form. And these data would support that argument. So we had this review paper where we argued for this position, and we had this diagram, and to us this was the conventional understanding of the relationship between AFib and stroke, where you have risk factors that cause an abnormal atrial substrate like atrial dilatation, and then that causes AFib, and the AFib causes stroke. And we argue that this model is more complete. It better fits the facts if you put an arrow directly from the substrate to stroke, so that in some cases the substrate might cause a stroke even before you have AFib, or in a patient who maybe never goes on to have AFib. And I think the reason why this concept is exciting to think about is that we have really good evidence that anticoagulation prevents stroke in patients with known AFib. Right? There have been numerous randomized clinical trials. It's probably one of the better established facts in clinical medicine. And given the parallels between this atrial cardiopathy and AFib, given how tightly they're intertwined, it's sort of plausible to think that maybe anticoagulation will also work for atrial cardiopathy, even in people who don't have atrial fibrillation. We have some supportive preliminary data for that. This is a paper from some of my collaborators who had shown back in 2013 when they did a secondary analysis of the WARS trial that you saw benefit with warfarin over aspirin in just the subgroup of patients who had high NT-proBNP levels. And then more recently, there was a subgroup analysis from the NAVIGATE trial, which again, in the overall trial, there was no benefit, but if you look at patients who had left atrial enlargement, there was a dramatic benefit from rivaroxaban. So at this point, I think everyone agrees there's time for a randomized clinical trial. We have the Arcadia trial that's ongoing. We're taking patients with ESUS. We're taking only the subgroup of patients who have evidence of atrial cardiopathy, and we're randomizing them to apixaban or aspirin. We're about a third of the way done. We actually just got our 363rd patient randomized today, so we're a third of the way done. And hopefully in a few years, we'll have an answer as to whether in this subgroup of patients with ESUS and atrial cardiopathy, is anticoagulation better than aspirin. I put the paper up here in case you want to look at more details about the trial. And there's other trials of sort of personalized treatment. The Atticus trial in Europe is looking at patients with cardiac risk factors as well. So I think, you know, given the state of where things are now, my sort of practical takeaways would be, for now, to use aspirin for ESUS and cryptogenic stroke, because that's clearly what the NAVIGATE and RESPECT trials would indicate. We should always look for AFib, so monitor patients who have AFib, because in those patients, you know, you should switch to anticoagulation if they have AFib, and then also try to enroll the patients in trials like Arcadia and Atticus, so we can see if there's better personalized treatments to prevent recurrence after ESUS. All right, thank you.